Good evening, everyone. I'm Namu. I'm the membership manager at CUH. Apologies for the delay. We were experiencing some technical issues. Thank you so much for joining us this evening for this informative lecture around new services and treatments for asthma. Without further ado, I hand over to Robin Stevens, our patient governor and host for this evening. Robin, over to you. Thank you.
Thank you, Namu. Thank you very much indeed. Also thank you to Robin Gore, who's the clinical head of the severe asthma services at Cambridge University Hospital, who's speaking to us this evening on asthma, how new medicines and services can improve lives. Just briefly, in advance of that, I'd just like to do a short advert, I guess, for Cambridge University Hospital membership and the programme, the benefits of joining. So firstly, thank you to all the members for joining this evening, and welcome to new members who have joined for the first time, particularly members of the public. CUH membership is free and open to anyone who is 16 years of age or older. Patients, carers and members of the public can become members. And we need members' opinions to help us to improve our hospitals, our services, and while offering health-related events such as this medicine for a members event, other lectures, listening sessions and other experiences across the campus. I've been involved as a governor for the last 10 months, and I found it hugely interesting and rewarding. So I can certainly emphasise the benefits of being involved. Also important to say that governor elections are being held, and voting will begin on Monday, the 22nd of April. We have 8 vacancies, so please do vote and be involved. Certainly, we would encourage all of our members and patients to vote, as you will be electing candidates who will represent your views and influence important decisions at board level and champion local community needs. And this will help us to improve the future of Addenbrooke Hospital and the Rose Hospital as well. For those who aren't members yet, they can sign up on our website, which is www.cuh.nhs.uk. So please do join and please do get involved. So now it's my pleasure to introduce someone else called Robin, which is a bit confusing when you organise it, but you have 2 Robins for the price of 1. And the topic is medicine for members' asthma, how medicines and services are improving lives and experiences. I don't know if anyone's had asthma or see people with asthma, but it's obviously involves frequent episodes of shortness of breath, wheezes, coughs, sudden attacks, which can result in hospitalisation. It's disruptive to a large proportion of the people, and also involves large doses of medication, often including oral steroids, which can result in long-term side effects. So I know that Robin has lots to share with us in terms of new developments, new drugs that can be used, and all the work that's gone into that. So certainly, I'm very much looking forward to hearing his presentation. Please do ask questions. The questions will go into the chat box, and we'll ask those at the end of the presentations. So Robin, over to you.
Thank you very much, Robin and Namu. And Namu is in control of my slides. So thank you, Namu. If we could have the first slide, please. Hopefully it's coming up. So yes, it's a great pleasure to give this talk, which is a distillation of many talks we do for asthma. So quite a lot to cover. I've actually renamed the talk Inside Out, and I'll explain that why in a minute. The 5 pictures across the top are we could turn this into a pub quiz if you like, but I'll make it easy. On the right-hand side, we've got a dog, clearly. Next to that, we have a house dust mite. In the middle, we have an important cell called the eosinophil. It's called that because it's red-coloured when you look at it down the microscope. And we're talking quite a lot about those. We've got some nice cherry blossom to the left-hand side. That's another very common allergen for people who are tree pollen allergic. And then on the very far left-hand side, we have something called aspergillus, which is a common fungus. So all of these entities are important to the asthma story, and we'll be mentioning them as we go through. Next slide, please. Just a quick plan. First of all, I'm going to talk about what actually is asthma, and then more particularly what is severe asthma. I'm going to be spending most of today's talk talking about severe asthma. We'll talk about 2 very common types of severe asthma, severe allergic asthma and severe non-allergic eosinophilic asthma. Don't worry too much about all the long medical terms. We'll go through what they are. Then we'll talk something about viruses and molds and pollution, because they're really, really important and really topical. And then we'll move on to treatments. And I do want to spend quite a bit of time today talking about the new therapies we have for asthma, which have transformed lives. There is a real good news story to asthma treatment now, and I really want to put that message across. Okay, next slide, please. So as always happens when I was doing talk, the video link doesn't work. So if you do have access to these slides, please do click on the box in the middle which says "What is asthma?" and that will take you to the Asthma and Lung UK website, which has a wonderful 3-minute presentation on what asthma is. But broadly speaking, asthma it's an umbrella term, really, but it refers to a syndrome caused by narrowing of the tubes. As you know, when you breathe in through your windpipe. That windpipe then divides into two, one pipe supplying the left lung, one pipe supplying the right lung, and each of those pipes divides, and each of those pipes divides, and so on 27 times until you end up with billions of small tubes taking air into your lungs and taking waste gases out. Now, what happens in asthma is that those tubes become inflamed. When they become inflamed, they become narrowed and boggy, and so the air can't get through easily. If you imagine trying to breathe through a hosepipe and then suddenly switching to a straw, you'll be able to understand why that makes it difficult to breathe. And the airways become narrowed by the swelling and the inflammation, and the muscles around the tubes also contract so that they narrow again. Most of you, I'm sure, will know all of this. Some of you will, statistically, 10% of you in the audience will have asthma, and so you'll know exactly what I'm talking about. This slide is just a bit of a safety check-in. If you do have asthma, you should have something on the top right-hand side called an asthma action plan. We know only one in 5 of you actually have one of these, but this is a traffic light-based scheme, red, yellow, and green, to tell you what to do when you're having an asthma attack. It means that you know when to call the ambulance, but it also knows that it also helps you know when you can probably just sit this one out, call your GP the next day, and use more puffs of your inhaler. It keeps you safe. If you haven't got one of those, check in with your asthma nurse at the GP practice. You'll all be familiar with peak flows. That's the device on the bottom left with the red collar that measures airflow, and that's used when you are having an asthma attack to help tell you how bad it is. And some of you may be familiar with measuring your peak flow on a peak flow chart, and that's the top left picture. And you'll see the bottom graph. You'll see the peak flow, or airflow, go up and down over several days. And for those of you who are particularly strong-eyed, you'll see that it's worse in the mornings. This is a really characteristic peak flow chart of an asthmatic, with the peak flows dropping in the mornings, and it's very erratic. It's very up and down, very sawtooth, and it shouldn't be. It should be much flatter than that. The top line is the red line. That's the peak flow going up or improving once the patient's taken his inhaler. Although you can see that as he gets to the end of the graph, he's written empty inhaler. So that's obviously a bad sign. He's running out of his inhaler, and he's been honest enough to record it on the graph. So that shows you what's happening in the asthmatic lung, with the tubes opening and shutting at critical points in the day, often narrow in the mornings when your asthma is bad, and not often open, a bit more open later on in the day. Asthmatics, they should all know what their best peak flow is. That's the bottom speech bubble. And then another thing that you should know, when did you last have your last asthma review with your GP? All asthmatics should have an annual review in general practice. Everyone's behind because of COVID, but that should be happening, and they're beginning to catch up. So if you haven't had one of those, then try and get booked in. Next slide, please, Nuri, thanks. There are different types of asthma. This is a very medically graph. I'm not going to dwell too much on it, but there are different types, and they do behave in different ways. But the thing that I wanted to emphasize is that the symptoms are all the same. It's cough, wheeze, breathlessness, often phlegm or sputum. Those are the same thing. and the airways are inflamed. They're boggy, inflamed, and narrowed, and the muscles are twitchy and hypersensitive. So that's common across all of asthma. Okay, next slide, please. Okay, so this is again a very medically side, but just look at the circles to the right hand side. That's a cross section of your airway, and the big white space in the middle is the airway. The grey circle is the inner lining of the airway, and then the white bit is a bit of soft tissue, and then you've got the pink muscle around the edge. Now, you'll see an expanded view of that on the left-hand side, and at the top of that graph, you'll see a load of rectangular cells. That's the lining of the lung. That's called the epithelium, and this is the barrier. This is the wall. This is the wall that stops those horrible bugs that we breathe in getting into your bloodstream and causing septicemia. That's what it's there for. That's why you've got phlegm and goo in the lining of your lungs. It traps all the bugs, makes it really difficult for the nasties to get into your body and give you a severe illness. So that's one of the things that the lung does. It's a defense organ as well as allowing oxygen to get into the body. So unfortunately, it has to deal with a number of assaults. The things that you breathe in every day, things such as viruses, bacteria, pollutants, and also allergens. These are proteins in the air that which we will talk about, which can elicit which can give an allergic response. So what the epithelium does, it processes all of these assaults, and then it orchestrates or coordinates the inflammation beneath the barrier and on the inside of the tubes that leads to the muscles around the airway also becoming inflamed and constricting, narrowing the airways. So normally, if you just click once on the circle on the right, just once, then something should happen. There should be another diagram coming, and there it is. Wow. Goodness, that's a relief. And so this bit did work. And so this is actually the airway now thickened. It's the airway's been assaulted by these allergens, viruses, bugs, pollutants, yucky things. And the airway you can see that it's narrowed. It's also, the wall is now much thicker. The pink lining, the muscle is thicker. That white wall has turned yellow because it's inflamed, and there's more mucus and gunge, both in the lining of the lung and in the bottom of the tube. So this is the asthmatic airway. And you can see that there's a lot less space left for the air to flow through, and so it's more difficult to breathe. So that is asthma, basically, in a nutshell. All right, next slide, please. So moving on from asthma to severe asthma. So there are some pretty picky definitions of severe asthma. There's something else called difficult asthma. I don't think we need to dwell on those really. They're essentially the same thing. Severe asthma, the people that we think have severe asthma and who we want to see are those people who have frequent exacerbations, frequent asthma attacks, have needed at least 2 courses of steroids in the last year, or have been in hospital at least once, possibly been on ICU, or if they've ever been unlucky enough to be on a life support machine for asthma, we definitely need to be seeing them as well. Some people have ended up on long-term steroids. They take steroids every day, and in this day and age, we should be able to get them off those. So we definitely need to see them. So if you know anybody in that group, then they should be seeing a respiratory specialist, and that could be a paediatrician if it's a young person, or it can be an adult physician. There may be some expert asthma paediatricians on the call today. One of my friends said she's going to join, so if there are paediatric questions, I'll be well supported. Finally, if somebody's using more than six or more reliever inhalers per year, these are the inhalers that open out your lungs and relieve the smooth muscle, then they need to be reviewed too. So because we've missed the introduction, I just need to emphasize that there are 2 usual types of treatment for asthma that all asthmatics will have. One is a reliever, often the blue inhaler, and that relieves the muscle, and that's what you take when you're feeling breathless. I'd say to people, if you feel as if you're going, if you feel as if you're going blue, take the blue one, because that's the reliever. But there's another one as well. There's another type of drug. It's an inhaled steroid, and that's the controller. And that's what you need to stop the asthma attacks from happening in the first place. And that dampens down the inflammation in the lung. If you had a heart attack, you'd take an aspirin every day to prevent a heart attack. If you're an asthmatic, you should take some inhaled steroid every day to prevent an asthma attack. Okay, next slide, please. So this is a little bit about severe asthma in the UK and about the what I would call the steroid emergency. Now I think you can probably click again because there's some more boxes below. So between 5 and 10% of asthmatics in adulthood are severe, and a very large proportion of those patients are exposed to using oral steroids every day. Depending on what studies you look at, it's somewhere between, 1 in 12 to, getting on for 1 in 2, 1 in 3, and long-term oral steroids are dangerous for the body, as we'll come to. Next slide, please. And the next few slides are just going to focus on that point and why we need to do something about it. Many of you asthmatics know this. Those of you who aren't asthmatic or don't have steroids maybe don't, but using lots of oral steroids can, when they came out, decades ago, they were revolutionary, and they are still life-saving for people with very severe asthma who are having an acute severe attack. But if you need them frequently, they will have side effects eventually. And we now have drugs to help us avoid using them. And the things that we really want to avoid are these effects: obstructive sleep apnea, diabetes, thin bones, high blood pressure, increased risk of cardiovascular disease, gastroesophageal reflux, depression, obesity, cataracts, and poor wound healing. And the list does go on. The weight gain with steroids is marked, and the average weight, the average BMI that we see in our clinic is 31, which is in the obese category. Patients have often just accepted that they would get bigger with steroids and bigger with their bad asthma, and just accepted their lot. But now we really do have the tools to be able to roll this back. Next slide, please. So what happens at a severe asthma appointment? So this is our team on the left-hand side, and this is not normally what our clinic looks like. This is a rare night out, which was richly deserved. So all of these people contribute to the service. What the patient can expect upon referral, and we receive referrals from general practitioners, from A&E, from intensive care units, is that there'll be a phase of gathering information on you, if it's you, before coming. We'll be inquiring of your GP how many inhalers you've picked up, how many courses of steroids you've had. We'll be getting records from other parts of the country if you've been admitted there. We'll then come have some lung function tests to just see how bad or good your airway caliber is at that stage. You'll then see one of our specialist nurses who will look at your asthma treatment and work out whether you're taking your inhalers correctly, whether you understand enough about asthma to treat it properly for yourself, whether you understand about steroids and whether you understand about the risks, and also if you're on steroids, whether you understand about the need to not come off them quickly. You'll then see the doctor, and there's 3 doctors in our service who'll go through the history, try and work out, firstly, is it asthma? And sometimes it's not. Sometimes it's the wrong diagnosis. Whether there are other complications along with asthma, and asthma does coexist with some other things that we have to treat at the same time. Many of the patients we see with asthma have what I would call wonky breathing. It's known as dysfunctional breathing or breathing pattern disorder, and that's where the breathing muscles become poorly coordinated and work against each other, and that can cause chest pain and worsening breathlessness, even if the asthma is controlled. So our physiotherapist is an expert in that field, and he can get that sorted out and make a big difference to people. Some patients have developed problems with their throat control, and they need the expert opinions of a speech and language therapist. And finally, we see many people who have suffered the psychological consequences of feeling breathless for many years, and they need help, and that's where the psychologist comes in. After that lot, we'll hatch a treatment plan, and it may involve one of the new treatments, which we'll talk about later. And that the person with severe asthma may then need referral on to a weight service if there's a pressing obesity issue, ear, nose, and throat, or something called the vasculitis service if there's a particular form of asthma. So all that takes about, well, that's a day case appointment, and it takes several hours to run through, but we can achieve a lot in that time. And often patients have had a very long journey and have been waiting for, have had years of symptoms and years of asthma treatment before getting to that appointment, which is something that always makes me stop and wonder. Next slide, please. So we've got this is what we. This is really just a summary of what I've just said, actually. I think we can skip forwards. Thanks. So a bit more about steroids. I did say I was going to bang on about steroids today because it really is a message I want to get home. I think that we've all been really, because we haven't had much else for so long other than steroids, we've all become very accepting of their side effects. And we've not really carefully studied the relationship between how much steroid you need to take before you get side effects. But there's a lot of great research now unpicking that. And we now know that if you have 4 courses of steroids in your lifetime, that's the point at which you begin to increase your risk of some of those side effects that we looked at. You can begin to measure that risk. And so we now that we have got alternatives, we want to see people earlier, really. And the other thing that we found is that we now know that many steroid side effects are baked in, so then you can't completely reverse the side effects. So the earlier we see people, the better, so that we don't get to that point. Next slide, please. These are the 4 drugs. They've all got very technical names, and I've given them their most technical names because in some cases there are different preparations available. Don't worry too much about these. I'll be talking about these in more detail to tell you broadly what they do. But essentially, the drugs that we use for people with the worst asthma, and these are people who have typically had at least 3 courses of steroids a year or are on long-term prednisolone. We see reductions in asthma exacerbations of, in some cases, up to 70%. And in some studies, we get 100% reduction in oral corticosteroid use, and we'll talk about that in more detail. So these are dramatic drugs with dramatic benefits. These are what are called biologic drugs. I don't really like that term because I think that puts some people off. But if you think of steroids as being a dirty drug, I always say to people, it's a bit like trying to hit a dartboard with a lead shot. You know you're going to hit the bullseye, but you're going to hit everything else around it as well. You're going to hit lots of other cellular processes in the body, and that's why you get lots of side effects. Whereas these are more like magic bullets. These drugs, they maybe latch onto one protein in the body using what's called antibody technology. Because we now understand the pathways of inflammation, how inflammation arises, they can selectively knock out, almost like a sniper shot, really, the critical bit that results in the inflammation in the lungs improving. Okay, next slide, please. Yeah, so I think we'll leave that. Next slide, please. This is the magnitude of the problem that we have. It's the old iceberg effect. We believe from modelling studies that in the east of England, there are probably around 6,000 untreated severe asthmatics who would be eligible for a biologic. The team here, together with partners across the east of England with whom we work very closely, have probably treated about 800 so far, and that's since 2016. So of course, to that 6,000, people are being born, people are getting older, that will continue to increase. So we need to accelerate what we're doing because we haven't really anywhere near caught up, and that's the challenge. Next slide, please. Okay, let's just go into talk a little bit about the 2 different types of asthma we said we'd talk about. These are all real examples. This is a young 17-year-old lad with severe allergic asthma. The important bit really is just on the left-hand side. He had asthma onset around about the age of 8. He actually had some baby eczema, which resolved, and many patients with allergic asthma do at some point have had eczema. He has rhinitis, or he gets itchy runny nose, which occurs year round, but it gets a little bit worse in the grass pollen season, which is, as you know, late spring into summer. He finds that he can't exercise quite as much as he would want to. He's finding sports at his college difficult because he becomes breathless and wheezy. His nose has actually been bad enough to be blocked and require a trimming in the past, a turbinectomy, which did improve his airflow. And the important thing is that he's been up to A&E twice, ED twice for asthma attacks, and has had another couple of courses of steroids in the past year. So he, in terms of the bottom bit, you would say that he has severe asthma. He's had 4 courses of steroids with 2 hospital ED admissions, poorly controlled disease. And the other bits on the right, I sometimes show this slide to our doctor trainees. These are more of the medical tests, but we can tell from the blood test he's got a high level of house dust mite allergy in his blood, and he's also allergic to grass pollen. We've also measured the number of that eosinophil cell we were talking about in his blood, and that's high, and that'll reflect the fact that he'll also have increased numbers of these cells or inflammation in his lungs as well. Next slide, please. So I'm going to talk a little bit about allergy because it's always of great interest. So when an allergen lands on the surface of the lung, on the barrier, we talked about the epithelium. If someone's highly allergic, it will induce and if the dose of the allergen is high enough, it will induce a very quick response inside 15 minutes. And you can measure this. This is actually airflow during what we call an occupational challenge, and a baker who was allergic to one of the components of flour, which is a very common allergic form of work-related asthma. And you can see that when you give the person the bread flour and measure their airflow, it quickly deteriorates. And either yourselves or people you'll know that they have allergies. You'll know that if they're very cat allergic and they go into somebody's house with a cat, there'll be a very quick deterioration in their asthma or in their allergic eye disease with itchy eyes and itchy nose. So allergy comes on quickly. If that happens multiple times per day, you build up inflammation in your lungs, and you end up with a longer term inflammation in your lungs and a longer term airway narrowing and swelling and breathlessness. Next slide, please. Allergens are all sorts of different sizes. And here's a model of the airway on the left-hand side. Pollen particles tend to be very big. Because they're big, they get stuck in the nose, and that's why they tend to cause hay fever rather than asthma. Though they can fragment and go down into the lungs and make asthma worse in some people. You've got house dust mites, which live in soft furnishings, which are medium-sized and go down to the lungs. And then you've got cats and dogs and rat particles, which are really tiny, and that means that they're very airborne. So that means that if you're very cat allergic, you share a chair with your mate at work, that cat allergen will be transferred into your workplace, and you may end up getting symptoms from your mate's cat, even though the cat's at home. So it's a very transferable allergen and very small, very easy to spread. Next slide, please. This is just to remind ourselves that soft furnishings have traditionally been thought to be the main home of the house dust mite. House dust mites love the damp, humid space in the middle of mattresses, and you probably don't want to know what's on the inside of your mattress, but if you do cut it open, it's damp and humid, and mites love it there. Next slide, please. But just a reminder that house dust mites are actually present elsewhere as well. And this study was done by colleagues of ours in Sydney, measuring house dust mites as you walk around during the daytime. And in fact, They're everywhere, not only in your bed, but also you're breathing them in your home office, in your office, in your workplace, except actually in hospitals. Hospitals tend to be allergen free because we just don't have the soft furnishings around. Everything's wiped down frequently. Next slide, please. Now, we mentioned something about fungi. We'll talk about fungi a bit more in a minute, but there are some people, interestingly, who get asthma attacks after thunderstorms. This is because the tension in the air releases fungal spores, it fractures them, and it also makes them more airborne. They're blown up from the grass and the crops where they tend to reside and fracture into small particles, which you then breathe in. And that can cause epidemic of asthma, causing a rush of asthmatics into A&E. It is rare, but there was such an outbreak here about 10 years ago, which my colleague Dr. Nasser actually published on. And so it's a nice example demonstrating that if you're allergic to some fungi, allergy can be important in giving you an asthma attack. Next slide, please. Okay, so we've talked about allergic asthma, and now I'm going to just mention the other type of asthma that we mostly see in our asthma clinic, particularly the adult clinic, and that's severe eosinophilic asthma. Now, classically, typically patients with this disorder are older when they develop asthma. They might be in their 40s, 50s. I think the oldest person we've had has been in their mid-80s. And they tell you a different story. They don't talk about cats and dogs making them worse or grass pollen. They may have had grass pollen hay fever in their younger days, but that's typically dried out by the time they get to adulthood. But what they do tell you is that that steroids always make a dramatic difference to them, which is great. But they also tell you that they need steroids every few weeks to few months. That they go in regular cycles of asthma attack. It's not unusual for patients to either have ended up on steroids when they come to our clinic here, or to say that they have had 11 or 12 courses of steroids in the past 12 months. And they may have even been doing that for the past several years with a really considerable steroid load. The lining of the lung is the same in the lung as it is in the nose. And so if you've got swelling in the lung, we tend to see swelling in the nose. And in this disorder, patients get what are called polyps in the nose, which can completely block the nose. And they'll have no sense of smell. And they'll have had no sense of smell for years and just given up on it. Sometimes they'll have had their polyps removed, which gives them some temporary relief, but they usually grow back. So in this case, this patient had just that. This is a 58-year-old female. It's a typical example. It's a slight female predominance here. We're now beginning to understand that around about the menopause or just after the menopause, asthma in women is worse than it is in the equivalent age men. So this is a really important group, and I would say probably 60 to 70% of the patients we see in clinic have this form of asthma. In this case, I've got some names of sputum bugs down the bottom. This patient is also getting recurrent infections with bacteria, which we need to tease out as well. And we do see that in some of our asthmatics. And you also see this person's BMI is 45, which is also, again, not unusual. But, you know, if they're 5'10", then their weight might be, for example, 135 kilograms, which is about 20 stone. So, you know, that's not unusual for the person who's in our clinic. Next slide, please. I can't. Oh, there we go. So going to, I think there's a slide missing of mine. It's going to go on and talk about viruses now and molds, and then briefly about pollution. So viruses are the commonest trigger for an asthma attack. And about getting on for 20 years ago now, there's some great work done up in Manchester showing that if you're allergic, you don't have to be allergic to have an asthma attack with the virus. But if you are allergic, it's the virus that makes the difference. What this shows is that if you're allergic to things like cats, dogs, house dust mite, and also are exposed to them at home. And in this study, that was measured. They measured the allergens. And if you then have a virus on top of that, you're much more likely to be admitted to hospital. So that explains why, if you are asthmatic, viruses floor you. We understand why that is now, and it does interact with the allergy. So it's important, if you do have an allergic tendency, that your asthma inflammation is controlled with your proper use of your inhalers, so that when you do get that virus, you avoid going into hospital. Next slide, please. Moving on to mold, I did say that there's an awful lot to cover today, and it's a very big audience with a broad range of interests. We're keeping it very much to severe asthma and severe asthma treatments, but I did just want, there's a lot of interest and concern around mold in homes, and many of you will have been aware of this the sad case of this young 2-year-old lad called Awa Bishak, who died in Rochdale a few years ago, and who was living in the most awful circumstances in social housing, with the house infested with mold. And the picture on the left hand side at the top is the house that he was in, published in the Manchester Evening News. And this led to the coroner concluding that fungal disease was involved in this young lad's death, and many of you will know that that's now led to a proposal for a new law, which will regulate social housing more strictly, so that hopefully we can avoid this sort of problem happening in the future. It's a really interesting area of research to read. There's incontrovertible evidence that strongly suggests the link between fungal exposure and asthma exacerbation in children, but we haven't got time to go over details today. Next slide, please. The next slide should be a picture of a house for those of you interested in why houses get damp. This is a nice article just explaining everything that can go wrong with your house, including problems with the windows, with the guttering, with the insulation, with occupant behavior and so forth. You may want to have a look at that. Next slide, please. So mold is a huge topic. We've got a whole lecture on mold. So that, yeah, I've only given you 2 slides, but that's I wanted to highlight that current issue. And of course, the next current issue is pollution. Again, a very similar sad story. This young lady, Ella Abukisi Debra, who was aged 9 when she died. She lived close to the London South Circular and had a series of asthma attacks running up to her at the end of her life. And the coroner asked one of the eminent asthma researchers, Professor Stephen Holgate, to investigate the circumstances of her asthma and of her death. And he took the timing of all her asthma admissions to A&E and linked them mathematically to the illegal spikes in pollution where she lived. And one of the things about the UK is that we do now have very good granular data on peak flow, on pollution air, on measures by almost by postcode, and he was able to mathematically prove that the pollution was a factor in her poor asthma control, resulting in her death. And the coroner, therefore, for the first time ever, made a ruling that air pollution was the cause of an individual death. And so that's why there's such a lot of interest now in, for example, expanding the ULEZ zone, electric cars, getting pollution down, because it really, 20 years ago, we'd say to patients, pollution, don't know. Now we've got some hard science behind it, and we really do have better understanding as to how it does impact on some people with asthma. The video is not working, but when you look at these slides, the link below, Cambridge traffic NO sampling, if you click on that, it's a fun video linked to a video taken by a friend of mine who runs a company called Combustion, which actually measures emissions inside engines. The companies are big engine manufacturers, but he's got a video taking his sampling technology in a pram around the streets of Cambridge, measuring pollution as it spikes as you walk past a bus. So we've now got the science to really measure personal pollution exposure, which I think is which is miles away from the technology that we had 10 years ago, and you may be interested to see that. Next slide, please. Okay, I'm going to rattle through these. Next slide, please. We did start late, but I don't want to spend too much longer. The first question is, how about getting rid of allergens in the environment? Does that help asthmatics? Well, you'd think it would do, because if you're grass pollen allergic, nature does that for you. And once the grass pollen season is over, or the grass pollen goes away, and your hay fever gets better. So it should be possible. Next slide, please. Next slide is on occupational asthma. And if you develop an occupational allergy, and so these are things like, well, the last one that I saw was somebody working with soap powders. You remember when they used to have enzymes in their allergens, and they had an outbreak with poorly contained working processes, and 20 patients developed severe asthma. We know that if you clear that up, get rid of the allergens in the workplace, and you catch it early enough, asthma gets better. Next slide, please. So what can we do in the home? You can get rid of your cat or your dog. Nobody ever does, and I've got a dog and I understand that. If you do that, it takes about 9 months for the levels of cat allergy to decline in the home down to a level of a house without a cat. But as I said earlier, cat and dog allergens are everywhere, so you can never actually really eliminate exposure unless you live in a enclosed cell. Next slide, please. So it's difficult to do. Some people have tried some crazy stuff, washing the cat. You can see Moggy here is really enjoying that. If that's not an evil look, I don't know what is. You can wash the allergen off for a bit and decrease cat exposure, but the cats produce their allergens very prolifically, and within a couple of hours it's back to normal, so that doesn't work. Next slide, please. Next slide is of a vacuum cleaner with a HEPA filter. Companies make loads of money out of this stuff. I wouldn't waste any money on it. It doesn't. They don't work. We've done studies to prove that. And so don't waste that money. Next slide, please. There is evidence for encasing mattresses and pillows to stop house dust mites from the soft bedding being breathed in. There's quite good evidence for that now, and so in house dust mite sensitized children, in particular with asthma, if you were to do one thing, then that is probably worth doing. But trying to get rid of all the other allergens in the home, it can be done. It's expensive, and it's worked in one study, but it's difficult to sustain, and the effect was small. So practically speaking, it's not a very effective proposition, I'm afraid. Next slide. Okay, so this is just to remind ourselves about that inflammation we were talking about at the beginning. And this time I put red boxes around some of the targets. I said to you that the lung epithelium or lining was assaulted by particles from the air, and the epithelium or barrier then orchestrates or coordinates the inflammation underneath. And because the scientists have done a lot of work trying to define these pathways, we know which chemicals or proteins we can knock out, and therefore reduce the inflammation in the lung and reduce the need for steroids. So there are several different targets there. IgE is the allergy protein, IL-4 and 13. There's one drug called dupilumab which knocks those out. Anti-IL-5, there are three drugs that do that: mepolizumab, benralizumab, and rituximab. And then there's another one called TSLP, and the drug against that is called tezepelumab. Don't worry about the names. These are all injection therapies. Next slide, please, Namu, thanks. Injection therapies, which we teach you how to, here they are, teach you how to give. They're mostly given every 4 weeks. In one case, they're given every 4 weeks, then every 8 weeks. Omalizumab, the anti-IgE, sometimes has to be given every 2 weeks, as does dupilumab. But in general, if you're on one of these, you're going to be injecting yourself at home, usually every month or two, and the side effects tend to be very minor. Like I said, these are sniper-like magic drugs, magic bullets, if you like, which are very clean. So the effects that we see, we tend not to see any allergy, or we really don't see any allergy to these treatments now. There was concern initially, but we don't. Some people get a bit of headache or sore throat. The biggest effects we see when we stop treatment are the side effects of withdrawing steroids, because people who have been on high steroids for a long time do notice the withdrawal, and we have to supervise that. But to summarize, these drugs have a massive, very significant effect. Next slide, please. And we're beginning to talk about a concept known as remission in severe asthma. In other words, we used to talk about remission in cancer. So we have never spoken about it in severe asthma, but it's now beginning to be debated, and there are some studies defining remission, and they're trying to see just how likely it is that you can achieve remission. And if we're going to achieve remission, we need to get you off your steroids, we need to have you free of exacerbations, and we need to have you feeling so good that your asthma control score, which tells us whether you're breathless or you've got chest pain, you've got a nasty cough, you're waking up, all that has all gone. So your asthma is well controlled, and you're not in and out of A&E, and you're not having the steroids. So that's what we call three-component remission. And with these drugs, we're beginning to see remission rates of over a third, which is terrific. For those patients on maintenance steroids, we're getting people off steroids in up to 80% of cases. Next slide, please. I think it's just another box, actually. Nabu, so similar data. So just whiz on to the next slide, please. Thanks. Yeah, and the top right picture is the Holy Grail. The other thing that we're getting much better at is weaning steroids quickly. Doctors used to do it by rule of thumb. Everybody used to do it differently, but we've now got protocols so that we've got an algorithm that we follow. If you're on this dose, we wean it down to that in month 1, month 2, month 3, and so forth. So we know how quickly and how safely we can wean people so that we get you off those steroids as quickly as possible, or down to the minimum dose that you need. Should just add in that if you have been on steroids for a long time, we wouldn't take you off completely. We'd get you down to 5 milligrams or 1 tablet, because the body does need a little bit of steroid to keep ticking over. Otherwise, you end up with a complication. Okay, final slide. I think it might be the final slide. No, I think we can skip that. This is the final slide. So in summary, patients needing assessment for severe asthma can be identified by needing more than two or more courses of steroids for the first year, and if you got more than 2, you may be into biologic territory or being on daily steroid treatments. So we really need to see you if you've got that. Steroids are life-saving in emergencies, but damaging in the longer term, and we've now got great drugs that allow us to reduce their use. Severe asthma centres such as Addenbrooke's offer a wrap-round multidisciplinary support and specialised treatments, and we work closely with other hospitals in the region who can offer a similar thing. We share care between a number of our different services over the east of England, so that we try and keep patient travel to a minimum. Big problem, I said earlier, we think about more than 80% of people who might benefit from this treatment have not yet been identified, and we're working on ways to try and identify people in that position more quickly so that they don't get these irreversible steroid side effects. And finally, I think that hopefully gives you some flavour of the fact that revolutionising housing and changing the air that we breathe could ultimately save thousands of lives. Thank you.
Thank you, Robin. That was a tour de force. It went a bit longer than planned, I think, but the content was so good. There's no hardship in that. So thank you very much indeed. There's lots there to absorb and take in. And if it's okay with people, obviously they don't need to stay on, but there are some questions. So if we don't mind, perhaps we'll go on maybe for 5 minutes longer. If there are questions that come afterwards, we'll try and answer those by email. Obviously, we'll have your details. But I'll just extend the session slightly, just so we can get some of the questions in as well. And also, there will be a copy of the presentation on the website. I think probably in a week's time. I don't know, Robert, if you're happy to share your presentation as
Yep.
well, but we can do that.
No problem.
Just going to the questions just briefly. Are there any plans? This is from Pam. Are there any plans for blue inhalers to have counters on, as it's crucial that they don't run out, but often it's guesswork if they are running out. The Foster preventer does have a counter, and that's really helpful. It seems obvious, so should there be a counter on the reliever too?
There should. I'm going to sort of change tack with that a little bit, in that we didn't have time to talk about this, but there's a big move to change the way in which we take the reliever inhaler over to what's called MART therapy. And so MART therapy is where you have one inhaler, which both acts as a reliever and a controller. And these are Foster is one, Civicort is the other. One's powder inhaler, one's a powder inhaler, or a squirty. They've all got counters on, so it's much easier to know when you're running down. The benefits of MART therapy, switching to one inhaler, and this will also ask the question above about carbon footprints.
Yeah.
Are that firstly, well, there's several benefits. You actually get better asthma control whilst taking in less inhaled steroid, and the especially if you switch to a dry powder inhaler, the carbon footprint is way below what you would get with a blue pressurized meter-dose inhaler or squirty inhaler. So that's actually a target. The NHS has green targets now, and there's work going on in the east of England within the respiratory network to firstly, all of the formularies, those are the menus that doctors can use to choose inhalers. They're all aligned now so that there are green choices for inhalers on all of the formularies in the east of England, and that should be nationally as well. But secondly, MART therapy, there's a big push to try and move towards MART therapy, and there's some project work showing that, well, in fact, two of our ICBs did project work in recently and published it, and showed that over a 6-month period, they swapped 800 people from the ordinary reliever and controller inhaler, the brown and the blue, to the MART therapy. They swapped 800 people, and they saved, I think it was 37,000 kilograms of CO2, which doesn't mean much to me, but apparently it was something like 40 New York return flights. So there's a lot of work going on there to get people onto MART therapy, because it's probably better for most. It's better for many people, and it may be better for most people. We don't like using it in severe asthma, in very severe asthma for reasons I won't go into. But most people haven't got severe asthma. They've got, poorly controlled asthma, which can be improved with careful adjustment of medicines and reducing triggers.
Thank you. How do you test the fungus mold in your home?
Yeah. Okay. So the best test is your eyes. Have you got mold that you can see?
Yeah.
So if you haven't got mold that you can see, I don't think you should panic. Mold is everywhere. We are right now breathing in, millions of spores of Aspergillus and Penicillium that we just can't see. They're absolutely tiny. The normal lung does a really good job of handling those. It gobbles them up and zaps them, and nothing happens. I had a picture of a pillow, but I didn't have time to put. I didn't have space to put it in. Pillows are wonderful incubators of fungus, and you'll have to know in the safe knowledge that you'll be breathing in fungus, and you won't know anything else about it. So you can't avoid mold. It's part of the biosphere. But black mold in damp houses is a problem, and the environmental scientists, when they go into houses and do housing surveys, one of the first things they'll do is, actually we did have a slide on this too, didn't have time to put it in. It's visible mold, it's a smell of mold, and they do mold counts as well using agar plates. And those are the things that they take into account when they're trying to quantify a moldy house. For most of us, if you haven't got visible mold, then you shouldn't have a problem.
No. Actually, this is one topic that I've seen, and certainly I've been told that you can find quite a lot of mold in washing machines without realising it. And if you put a dishwasher tablet through a washing machine, that will often clear it through. I don't know whether that's true, but I just share it for general consumption.
Okay.
So if it's wrong,
I didn't know that. That's interesting.
might be worthwhile trying anyway. This question I think could take days, but how do you make decisions between the different biological agents?
Yeah. Okay. That's not straightforward.
No, sure.
Sometimes it's clear from the. Okay. So the way that NICE has allowed us to use them, there are strict rules in place, and there will be times when the patient meets the rules for one and doesn't meet the rules for the other, but you know that the drugs are going to be equivalent, and that's quite easy. There are other drugs that sometimes we do have a choice and we have to weigh it up. We don't know the cost of these drugs because it's confidential. So that makes it, if you have got an equal choice, but you don't know the cost of the drugs, it makes it quite difficult. Let's take our first example, the young man with severe allergic asthma. And let's say that his allergic rhinitis and allergic conjunctivitis were also really troublesome for him. That might swing us towards a treatment, one of the biologics that's also really good for that, and that would be the anti-IgE. One of the other therapies there that we can sometimes use in that situation is dupilumab, and if he had eczema, we know that that drug's good for eczema as well. So that would be a good drug for him. Whereas the other drugs that we typically use for eosinophilic asthma, they're not that helpful for the allergic nasal or eye disease or the eczema. So that can help us make a decision. So it's taking a really good history, knowing what the other bits other than asthma are that are affecting that person, and taking a decision. Many of the patients have really bad nasal disease. I mentioned nasal polyps, and there probably are differences between the different drugs on how good they are at shrinking the nasal polyps, and that can sometimes help us make a decision as well. But we chew that one over. We discuss it in our MDT. And if there is a choice and we try one and it's not worked brilliantly, we might swap.
Yeah, thank you, Robin. I'll just do one more question because obviously time is cracking on. You mentioned the very large target patients that you're trying to get through. That's just in the east of England, and clearly this issue will be issue in every region. Is there a?
It is.
If you, yeah. Well, what can we do to try and accelerate the process? Is the one thing that we can do? Is it cost? Is it capacity? Is it training? What would you like to change? What can we change realistically over the next 2 or 3 years to try and accelerate the process?
Well, I think I think medicine's at a really exciting time now because we're beginning to finally change the way in which we streamline patient pathways, and general practice has got some great technology at finding. So you can type in. It's a bit like going onto Amazon and or eBay and searching and finding the one item you want with, the right color and right shape and the right weight. They've now got the processes in place in primary care to be able to pull out asthmatics who have had 3 courses of prednisolone, who have had an eosinophil count, who have been into A&E once, and actually go and find them, rather than relying on the person affected to traipse up to the GP and say, I wonder whether I should see a respiratory doctor. So we can now proactively find those people and identify them sooner. Then, of course, the question is, what do you then do with that? And I think we need to find a way of, and there's work going on to try and sort this out in the east of England. What's the next step? Because there aren't many consultants in asthma working in the field, but there are lots of other doctors and lots of nurses who can be highly trained to do some very comprehensive assessments for people who might be eligible for severe asthma treatment. So I think we can streamline the process. We now know, have confidence that we can do that, but we need to change the pathway so that it speeds up and we reach more numbers of people. And we need to decentralize. Actually, we need to kind of, not have we've been doing that for some years. We've now got lots of people starting treatment around the region, not coming to Edinburgh to start, and that will just accelerate. So it will take some investment, and that's the trouble. But at the same time, getting people onto these treatments will result in fewer exacerbations, fewer hospital visits, fewer intensive care visits, and in particular, fewer costs from the steroid complications. We don't know how much they cost at the moment, but we're finding out, and I think that'll be a massive cost saving. So I think we can make an argument to the NHS to try and invest in this.
Thank you very much indeed, Robin. That's been well, it's been fascinating and clearly very, very important as well. So thank you for your time today. I'm sure everyone who listened to the presentation has learned a lot, as I have. As I mentioned earlier, a copy of the presentation will be online soon. Robin will also share his presentation as well. If I can ask you to complete a short survey for those people still on the line, but on the link on the page as well, that will be helpful. Thank you all for joining, and certainly look forward to learning more. And I hope your plans and aspirations for the future, Robin, are achieved. It's very, very important. And thanks again for your time and input. Much appreciated. Thank you all.
Thanks for joining, everyone. Thanks for your interest. Okay, good night.
Thank you. Bye bye now.